conversations will impact our lives on so many levels and so in so many places we haven't even thought about, but they will impact our lives. And we, you and I, have to understand it, and we have to understand the place of research in that whole entire process. So today, I want you to know we have Dr. Paul Christos with us, and he is the Associate Research Professor of Healthcare Policy and Research, who received his doctorate in public health and epidemiology in 2009. He has a master's in biostats and a master's in epidemiology in 1995, all from New York Medical College School of Public Health. Prior to joining Weill Cornell Medicine College in January 2000, Dr. Christos worked as a biostatistician and epidemiologist at Strang Cancer Prevention Center, and later as a biostatistician in the dermatology service at Memorial Sloan Kettering Cancer Center. During that time, he also served as an adjunct faculty member in the Department of Public Health at Weill Medical College and in the Department of Health Quantitative Science at New York Medical College, where he taught introductory epidemiology and biostats to medical and graduate students. Dr. Christos is the director of the Research Design and Biostatistic Core of the CTSC. In this role, he directs the administrative structure of the Research Design and Biostats Core. In addition, his ongoing CTSC responsibilities of developing, organizing, evaluating, and teaching courses, mentoring junior investigators, and writing protocols and proposals, reviving protocols, developing new statistical methods applicable to translational science, providing analysis of data for projects through the RDBC, and participating in the National Biostats Epidemiology and Research Design Consortium. He is also the lead biostatistician of 2 clinical studies evaluation committees of the Weill Cornell Joint Clinical Trials Office, as well as the lead biostats on the Adult and Pediatric Translational Research Advisory Committee. Today we have before us a man well learned, full of wisdom regarding biostats and maybe other things, but I know for sure biostats and epidemiology. And if any of you are thinking of preparing yourselves to do some form of research or get involved in applying for one of our pilot awards that I'm gonna talk more about it later on, I want you to listen carefully to Dr. Christos and know that he's available to you and to your organization. So fill up with questions, and you can write the questions down. You may not have a question today, but if any question comes up regarding research, write it down and get prepared to get in touch with Dr. Christos. So the next voice you're going to hear is Dr. Paul Christos. Welcome. Thank you.
Thanks, Lumi. Appreciate it. Everybody, thanks for attending. So a couple of corrections. My department name actually changed over the last year. So now we're Population Health Sciences.
Oh,
so
okay.
They change every few years. And
okay.
The core that I run, actually, it's the RDBC was the name we used to have, but the CTSC grants typically all the different institutions that have CTSCs. They all have a common core that looks at biostatistics and epidemiology. They're called BIRD cores, so biostatistics, epidemiology, and research design. So we're really just sticking with that name to be kind of consistent now across all the cores. Gotcha. And again, like Lillian mentioned, I pretty much run or work with this core where we actually work with investigators at Cornell, other institutions as well, helping them design studies. Early on in the design of the study, we're involved, could be involved at the analysis phase once the data is ready to be analyzed. And we have a staff of about 20 or so statisticians, masters and faculty statisticians that kind of work on various projects. So what I'll try to do today is just talk about how to communicate with the biostatistician early on when you're designing a research study. So some of it might seem a little technical, but it's really just kind of little points and guidelines to how to interact with a statistician. So let me just advance the slide here. So we can also think of it as the statistical consulting process. When do you engage a statistician in your study? So typically, if you're designing a research study from the very beginning, you want to involve a statistician early on. So this could be at the point where you're actually writing up the protocol. So for example, at Weill Cornell, we have these protocol review and monitoring committees that will look at any research being conducted. And they'll always advocate for a statistician to be brought on early on to help partially write the method section of the protocol, help write the statistics section, which kind of dictates how the analysis will be carried out going forward. So early on is really good. And typically, if you're meeting with a statistician, let's say you're designing a study, early on, if you're meeting with someone, you could email me directly, for example, and we would assign someone to work with you, or I would work with you. But typically at that meeting, kind of you can think of it as that initial meeting, we would have the study protocol, or you as the investigator would bring like a draft of the study protocol. What type of instruments are you going to be collecting, or how you are measuring variables on the patients you might be looking at? What's the relevant background literature? Are there any existing data sets that you have where you've already collected some data on the subject? So typically the statistician will not be an expert in your clinical area. So you'll have to kind of bear with them and kind of keep it simple in terms of how to explain the subject matter. So typically you just start with an initial discussion, a summary of what your primary aims might be for your study. Just explain the clinical terms that are really relevant to that study, to your study. So the statistician will typically ask a number of questions, mainly centered around, what is the main outcome you're trying to assess? We call that your primary endpoint. So if you're looking at, the incidence of a disease in a specific group of patients, that might be your endpoint. What is the incidence of that disease at a certain point in time? How do you measure it? How do you characterize it? We try to avoid a lot of technical terminology, at least when you're having that initial meeting. And it's good not to jump around. Ideally, a protocol or a research study should have one or two primary aims, primary objectives. Sometimes you'll see a lot of these exploratory studies where they'll look at many different things, but that's typically very messy. So it's really good to have one or two primary endpoints, primary outcomes that you're trying to assess. And feel free to jump in if you have any questions, just interrupt me. So typically when you state your research question as you're kind of writing up your protocol, your grant, whatever you might be doing, we'll call it like a clinical research study. You want to have, ideally, what's your primary exposure of interest, like a risk factor the patient might have. What's your question, basically? So we kind of lay that out as, what's the exposure variable? We call that X. What's your outcome of interest? So an exposure might be, exercise could be the exposure. Your outcome might be heart disease. So maybe you're doing a study looking at the relationship between exercise and heart disease. And P is your population. What specific group are you studying? Are they hypertensive patients? Are they patients with diabetes? Is it the general population? Who are you looking at? And the basic question would be, is X, you could think of X as your risk factor of interest. Is X associated with a change in Y? Y is your outcome in that population. So, for example, is, high intensity exercise associated with a reduction in risk of heart attack, in a given population of hypertensives, whatever it might be. They say the question should be SMART. They have this kind of acronym where it's specific. Do you have one or two primary objectives in your study? Is it measurable? How do you measure the endpoint? If it's an obvious endpoint like an MI or a diagnosis of a condition, that's obviously very quantifiable. Is the study attainable? Do you have the adequate resources to carry out the study? Is it relevant? Is it a novel question? Is it clinically meaningful? It doesn't always have to be novel. You might just be doing a study where you're trying to reproduce, other results to see if it's consistent. And is it timely? How long will it take for data collection? If it's a clinical trial and you're following patients over time, or like a cohort study where you follow patients over time, how long does it take the outcome to occur? If you're looking at, incidence of a disease over time, what's the latency period of the disease? It could take a long time for the study to be finished. Typically, when we're writing up these research studies, you want to discourage like a bad research question, which by definition tends to be very vague, unfocused. It's not really quantifiable, or it's not clear how it's going to be measured, versus having it be very specific, very focused. Is there an actual instrument to measure the outcome? Is it an ICD-9 code or 10 code to quantify a diagnosis and so forth? And is it feasible to actually conduct the study? So an example of a bad research question might be, or kind of a general non-specific research question could be, is radiation therapy helpful or harmful? So this might be, an investigator might be conducting a study looking at this, but that's a very general statement. So the good research question, kind of unique to that individual's research of interest, might be very specific. Is there a difference in overall survival between stage 3A non-small cell lung cancer patients who receive postoperative radiotherapy versus those who do not receive postoperative radiotherapy? So now you have a very specific question. Your primary outcome is overall survival, which is typically, as you follow patients over time, just mortality, death from any cause. But they're comparing two groups, those that received postoperative radiotherapy versus those that did not. But their population of interest is very specific. It's just stage 3A non-small lung cell cancer patients. So that's their population of interest. Their predictor, their exposure in a sense, is whether or not they received this type of treatment, kind of yes or no. This would be like your classic clinical trial, perhaps, that would kind of lend to that question. So then when you actually do your study, how are you going to collect the data? What are your variables of interest? So how are the outcomes and exposures measured? Are they continuous? So a continuous outcome might be like blood pressure. Maybe you just want to see, is there a reduction in blood pressure with a new treatment? But you're going to keep the outcome continuous, meaning, what is the mean blood pressure, after some months of treatment? Is it ordinal, meaning is your variable categorized, like in low, medium, high, something like that? Nominal could be like a binary example, either just you survived or you didn't, disease, no disease, something like that. So you kind of have to define these up front before you would even meet with the statistician, or the statistician would kind of explain how to characterize these. Then we talk about what are potential confounders. So, you might be designing a study to look at the relationship between a new treatment and some outcome, let's say a new treatment for diabetes, for example. So the treatment is, in a sense, your exposure, and your outcome, say, is diabetes. But what are some potential confounders you worry about? Confounders are things that might get in the way of that relationship, like age, biologic sex, comorbidities. These are variables that might impact the outcome separately from the treatment. If it's a randomized study, it's not quite as important, because randomized studies, both groups should be very similar on all other factors, except for the treatment that you're giving. But if it's a case control study or a cohort study where you don't randomize patients, you always have to worry about confounding. Could there be other variables that are going to mess up the association you're trying to detect between some treatment and some outcome, some exposure and some outcome, for example? So this really is a discussion early on with the statistician. They'll ask you these types of questions. This might be a little bit technical, but if you're actually going to be doing a study and collecting data, how do you assemble the data? Typically here at Weill Cornell, many institutions will use REDCap, which is a kind of a CTSC-sponsored database that kind of collects the data for you. And it's pretty user-friendly. You kind of have nice screenshots of the instrument that you might be using to collect data. They can enter it directly onto the computer. But essentially, behind the scenes, the data is stored kind of in the background, almost like in an Excel file. And as you kind of look at that data file, you want to avoid things like, I want to look at column AE in my Excel file. Basically, you want to label everything very clearly. So they call that, a data dictionary. So what are the variables you're looking at? And have like a kind of a coding sheet or a dictionary that kind of defines the name of the variable, where it is in the file, things like that. The range of each variable. So if you're looking at some type of comorbidity, what's the range of that variable? Let's say you're looking at education. How many categories do you have education classified into in the data set? Things like that. So this typically, big data sets that you might get off the internet that are publicly available will always come in like SEER data or any kind of, national database. Will have a data dictionary that comes with it that tells you exactly what's in the file and how those variables are coded. If you're doing it yourself, your own little study, let's say locally, when you're entering your data, you want to make things clear as possible. So, for example, if you're entering a date into the Excel file, you want to be consistent. Don't have like multiple versions of that date. You want to avoid text. Like if you're saying something is either negative or positive, just say 0 is negative, 1 is positive. So you'll have like a coding sheet. You don't want to type in 0, 0 neg, because then if you try to bring in this into a statistics program, you can't really analyze it. You have a lot of what they call data cleaning to be done ahead of time. So typically, who's ever helping you with your study, a research assistant, a data manager, will typically help to kind of make the file as clean as possible. And it's good to meet with a statistician early because they'll tell you how to go about to do that. Many clinical databases are kind of created, in the clinic for visual purposes, and the investigators are not thinking in terms of analysis. So they might just kind of write notes in the file, comments. They might have, if you think of Excel, you might have like one patient on each tab in the file or different rows and columns, which gets pretty messy. So basically, your data set typically, general rule, every variable in your study should have a column in the Excel file. Each observation typically has its own row. An observation might be a patient, and each value must have its own cell, kind of in the simplest design. So when you're handing over your data to a statistician, let's say you've collected some data, you want to avoid highlighting in the file multiple sheets in your Excel file. Sometimes investigators will have like some preliminary graphs right in the file to begin with, and it's kind of messy because you're handing the data over to a statistician to help look at it, to analyze it. And you'll have a lot of cleaning to do up front before we can do that. So these are kind of some of the points to, as you kind of store your data, like in a simple study, let's say it's only 100 patients, you're entering it into a simple Excel file, how you want to set it up and make it clean. One quick example of that, this might be, you've collected some data, you've got like a column here, a certain type of condition for the patient. It's got like 1, 2, and 3 here. Then over here, you've got like, tumor size or path size, right or left, but see how in the column they've got text like R and L mixed in with 3.5, they've got dashes. So at the end of the day, I might want to know, like, what is the mean path size for these patients? Let's say this is like tumor size. What is the median or the mean tumor size for this type of cancer, let's say? I can't do anything with this column because this column has numbers and text written in. So I can't do any kind of summary statistic on this column. So I have to clean it. I have to kind of pull out left and right, make that one column of its own. A lot of it's pretty obvious. Path size is by itself, kind of a nice numeric variable. This patient down here, they're missing their path size, but you don't want to put the question mark over here. You want to remove it so it's just blank. So if I were to input or bring this into a statistics program, let's say I wanted to calculate the median, I could do it on this column, but I wouldn't be able to do it over here. So you'll have a lot of cleaning typically ahead of time when you collect data. The much bigger data sets that you get that are more national, data sets are well maintained already, kind of in this format. So it really depends what type of study you're doing. When you work with a statistician, when you collect your data, when you hand over the data to the statistician, you want to make sure you've removed all these, HIPAA identifiers from your data sets. So again, if you're collecting data in the clinic, you're obviously going to have all this information in the file, in the whatever database you might be using. But when you bring it over or turn it over to the statistician to help analyze it, you obviously want to remove all these identifying components. You just want to have kind of a code for the patient, and then whatever their outcomes and exposures might be. So when you're designing your study, one other question might be, how do you define your sample? Where are you sampling from? So what clinical population will you study? How will you collect the data? Are there constraints in terms of collecting the sample? So the different types of sampling, simple random sampling is probably the hardest to do. So in other words, let's say my question is, I want to look at hypertensive patients and in New York City, and I want to maybe give some kind of a intervention to them. So this kind of what I'm circling here might be all hypertensives in New York City, which I can't really measure because I can't measure everybody. So ideally, you might take a sample of all these people in the population. That's called a simple random sample. Kind of hard to do because in that case, you'd have to kind of enumerate everybody and then take a sample from that population. But if you could, that would be ideal because everybody has an equal chance of getting into the study from that population. So this is kind of like the foundation of a lot of the statistical tests that you see in the literature where they talk about p-values and a t-test or whatever chi-square test. When you see those terms in the literature, they're kind of based on this concept of simple random sampling, but it's not real. We can't really do that too much in practice. More commonly, you might have something like stratified sampling where, maybe you're doing a clinical trial, but it's multi-center. So maybe, the clinical trial will be conducted in, let's say, hypertensive patients, but we're going to stratify initially on center, like maybe we're doing a multi-center trial. Maybe we're going to do, we're going to use Mount Sinai, we're going to use Columbia, we're going to use Weill Cornell. Those might be your strata. And then within each hospital, we'll sample from that population. So we'll randomly sample from this hospital right here, and maybe we'll put them, some get treatment, some get control, and so forth. That's called stratified random sampling. That's pretty common in a clinical trial. Cluster sampling is also pretty common, where if you think of New York City, for example, in let's say a population of hypertensive patients, this might be, one specific hospital where, like here, I'm doing a study just here at Cornell. This technically is a cluster. It does not represent all possible hypertensive subjects in New York City. It's just one hospital. But that's convenience, right? You're doing your study internally here at Cornell or wherever you might be. That's considered a convenience sample or a cluster sample, which is fine. That's typically how it's done in most research settings. Then the question becomes, typically when you meet with a statistician, what sample size do I need in my study? So that gets a little technical, but typically the sample size will enable you to measure what you're looking for. So if you're trying to see some association between a treatment and an outcome, you need a certain number of patients to be able to measure that. So, and it really depends on a number of things. What type of an effect are you looking for? So if you think the new treatment could lower your blood pressure by, 10 points, 10 millimeters mercury on average, that 10-point difference you might be looking for, will I be able to detect it in my study? They call that the power of your study. Is your study powered enough to be able to find that difference if it's real? So that's where a statistician will come in. They will tell you, the sample size you'll need to be able to detect what you're looking for. And that requires a lot of back and forth between the statistician and the investigator. It's good to have some pilot data or some previous studies to help get some of those inputs, but there's ways to kind of get to that. Sometimes the sample size is fixed. I mean, you might ideally go to a statistician and say, how many patients do I need to enroll in my study to be able to find the effect of this drug? That's one way to do it. Sometimes it's fixed where you already know your sample size. You have 100 patients available to you at a clinic. That's all you have. And then typically we work backwards to see, can we measure something given that sample size? What can that get us in terms of statistically evaluating some association? So there's two different ways you can think of it when you're designing a study. There's questions of description, which are more simple. In this case, a sample size calculation will just be based on precision, meaning how precise is the estimate that you're going to be getting. So for example, just a simple example, an investigator might come to a statistician and say, I plan to prospectively collect data on about 200, intensive care patients admissions. And the 200 might just be a convenience number because that's what they have available to them. They expect that about 15% of these patients will develop delirium during their stay. So delirium basically is in their study, that's their outcome of interest. They want to measure it. And so they're going to do this study with about 200 people. They think the rate of delirium is about 15%, but they don't know. But they want to look at those 200 patients and then kind of prospectively see how many actually had delirium. So it's a simple study where they're just trying to look at the incidence of delirium, hospital-induced delirium in that population. So the statistician might tell you, they'll run a calculation, with 200 patients in your study, a 95% confidence interval. And a confidence interval is just a way to assess how precise your result might be. For the proportion of patients who develop delirium, can be constructed to be within about plus or minus 5% of that proportion. So in other words, if it turns out the incidence of delirium is 15% in your sample, we would say 15% plus or minus about 5%. And the smaller this number is, that's better. So in other words, you want your estimate to be precise. The 15% delirium cases among these 200 people is just one study. So the idea is, how precise is my finding? So we put a range of precision around that. So with 200 people, you can get this estimate to be within plus or minus 5%. So it could range anywhere. In reality, it could be between maybe 11% up to 19%, which is a pretty narrow range, which is good. The bigger your sample size, the more precision you'll have. So in this case, sorry, go ahead. Question, yeah.
Pardon me, Doc, question.
Sure.
John Ruiz here. How do you get to 4.9%? Where did that number come from?
This would come, yeah, you would run a calculation. So a statistician would use a calculation to calculate the confidence interval. What it does is it takes into account the sample size of 200. It looks at an estimate of the proportion. If you kind of going in, you assume about 15% will have delirium. That goes into the calculation. And a couple other things actually would calculate this confidence interval. So, if you were to Google, sample size calculator for a proportion, basically what would come up would ask you, what is your estimated proportion? You would say 15%. What is your sample size? 200. And there's a formula that would generate this plus or minus 4.9%. So we can't do it here, obviously, but that's kind of how you would do it. Many programs can do that for you, like SAS or R, or you can just Google a calculator. Yeah.
So I'm sorry to interrupt again, but I'm trying to understand. But the 15%, how did you arrive at that number?
That's a good question. Yeah. See, everything with statistics is really based on assumptions. It's not really a hard science. So you have to kind of going in, you have to have an estimate of what you think the incidence of delirium will be. And let's say you think it's about 15%. It may not be, but given that you're assuming it's going to be around 15%, if that's what it comes out to be, you'll get a range around it. Even if it's higher, if it turns out being 20%, 5%, you'll still get, with a given sample size, you'll be able to know some level of precision around your finding. But there are a lot of assumptions that go in. Number one, do you have an estimate of the delirium incidence proportion? You have an estimate of your sample size. Is it 200? Is it less? Those all go into the calculation. So, and the only reason we're doing this is because when the IRB or whatever committee is evaluating your study reads this, they basically want to say, well, how precise is your finding? So whatever it might come out to be, with this sample size, I have a pretty good precision around it. It's plus or minus 5%. It's not like it's 15% plus or minus 20%, where it could be, or 12%, a much wider interval. So, but yeah, we can't obviously do that today, but there are formulas and calculators that would calculate this for you.
Okay, thank you, Doctor.
Sure. Questions of comparison are more common. That's where the investigator is actually trying to compare two groups. So in the first example, they're just simply, looking at these patients, and they're going to measure the incidence of delirium and kind of stop there, just describing it. With a question of comparison, they might be comparing two groups. So in that case, you have a difference you're looking at between the two groups on some outcome. It could be the same question. Maybe I'm looking at the incidence of delirium between group A versus group B, whatever that might be. And then we get into the concept of power. How much power do I have? They call it statistical power, to be able to detect that difference. In that case, you as the investigator have to really have a sense of what's the difference you're looking for. So like I said, with blood pressure, if you were hoping some new treatment could lower blood pressure by about 20 points on average, 20 millimeters mercury, let's say, that little difference of 20 points in blood pressure, I would come into the meeting with that. And then you'd also have an estimate of the standard deviation, which is, kind of an estimate of the variability in blood pressure in general. So all these kind of go into the calculation. And then it all goes into a calculation, which would tell you how many patients you need in the study. So for example, here's another one. An investigator says they anticipate to retrospectively collect data on 500 patients. They know that about 70% of them have this poly-sensitized allergy, and the other 30% have a mono allergy. So we're kind of comparing two groups, those that have poly versus those that have mono, in terms of their allergies. And their outcome of interest here is asthma. And they want to know, is there a difference in the proportion of persistent asthmatics between those two groups? So in other words, the group that has multiple allergies, are they more likely to have persistent asthma compared to the group that has, the mono allergies? And they might tell you, they're telling you, the investigator is stating up front, they have about 500 patients available to look at. So the statistician would run a calculation, and they would say, well, with about 350 people in the poly group and 150 in the mono group, and the reason why we have 350 versus 150 is because of the breakdown. We already know about 70% will have the poly allergies, 30% have the mono. That's just the way it works in that population. So you'll have more in one group. So with 350 and 150, a chi-square test, which is a statistical test you would use to compare proportions between groups, will have 80% power to detect a 13% difference between the two groups. So in other words, let's say in the mono allergy group, the incidence of persistent asthma, however that is defined, might be 57%. 57% of patients will have persistent asthma. We think it's going to be higher in the group that has the multiple allergies. So that difference of 13%, you could be more specific, 10%, 20%. The difference of 13% between this and the 70, let's say I think that's a reasonable difference to be able to measure. How many patients do I need to be able to give me a 80% chance of being able to detect that difference? So the 80% means your study has, if the difference is real, if the polyallergies really do increase your incidence of persistent asthma by having those multiple allergies, your study will have an 80% chance of detecting it, which means there's still a 20% chance you might miss it. That's called the power of your study. And you'd like it to be 100% power, but this typically is driven by your sample size. So typically when you meet with a statistician, you come in with this information. How many patients are realistically available to look at? What's the difference you're looking for? The difference in the outcome, in this case, persistent asthma. And I want to have at least 80% power, which is kind of your gold standard. If you're writing a grant or any kind of research study or a manuscript, they'll always require the granting agency, the journal, wants you to have at least 80% power to be able to detect what you're trying to find in your study. And then we test out what they call 0.05, not so important today, but so these are all the inputs that kind of come in to this calculation, which the statistician will run for you. The main point here, though, is that when you're meeting with a statistician, you have to have kind of estimates of these things coming into the meeting. You can't just say, how many people do I need in my study to get a significant result? They talk about statistical significance. How many people do I need to enroll in my study to find a significant difference in asthma between the groups? That wouldn't work because you need to know upfront, what is the difference you're looking for? How many patients are available? What's the breakdown of those that have the polyallergies versus not? If it's a clinical trial, it's a little bit easier because you might just have the same number per group. I have 500 in one group, 500 in the next. It's a randomized study, and I want to look over time for the incidence of asthma. That's fine. But again, you'd still want to know what is the difference you're trying to detect.
Yeah, doctor.
Yeah.
Could you define the two-sided alpha level and what's the?
That kind of gets into a whole kind of stats topic. But typically, when we do a research study, we assume going in that nothing's happening. So they call that the null hypothesis. So going into a clinical trial, for example, let's say I'm comparing treatment versus control, new drug versus control or placebo. I assume going in that the new treatment will have no effect. That's what the null hypothesis would say. And then you as the investigator are trying to prove that there is an effect. So the 0.05 means it's kind of hard to explain it, but basically when you do a study, you assume going in that there's no difference between the groups. And then on that kind of scenario, we look for things that occur less than 5% of the time. So if the null hypothesis is correct, we should see no difference between drug versus placebo in terms of the outcome. Let's say, the incidence of some disease. If I do a study and I find a difference that's not likely to happen under that null hypothesis, we make a decision. And we say if it's less than 5%, we're going to, what they call that, rejecting the null hypothesis. It basically means that, if the null were true and the drug was no better than placebo, the likelihood you would come up with the difference that you observed in your study, let's say you see a big difference between drug and placebo in terms of the disease, which is good. The likelihood that would happen under the null is less than 5%. So when they say p less than 0.05 in the literature, that means your finding is your study result was very unlikely to happen if the null hypothesis was correct, and then we make a decision to reject. That's confusing. You have kind of, the first 1 or 2 or 3 lectures in a kind of introductory statistics course. We spend a lot of time on your alpha level and kind of the meaning of it all. But that's kind of the gist of it. We look for things that occur with a small probability under the null hypothesis. So if the null were correct, you go out and do a study, you find the drug works. How likely would that happen if the drug really didn't work? And that's the alpha level. Two-sided just means that they're considering both possibilities. Like in a clinical trial, you might, as the investigator, believe the new drug, let's say it's a clinical trial to lower cholesterol. You as the investigator probably think the new drug will do better than the old drug, and you'll lower cholesterol, you'll reduce it. But, what if the opposite happens? What if the new drug actually increased the cholesterol in the patients for some weird reason? Two-sided means you're covering both possibilities. Maybe the difference will be in one direction or not. That's called a two-sided test. Most journals, grants will always require a two-sided test to cover those both possibilities. Not always, but most times they will. So these are all the things that go in. Power, what's your alpha level? 0.05 is kind of always what we test at. That's the small probability that we kind of look at. Sample size and so forth goes into this calculation. Yeah, you had a follow-up question?
No, I just wanted to know that 0.05 is a standard number.
Yeah, that's kind of the gold standard they use. You can make it smaller, like an alpha level of 0.01 is more conservative. That basically says we're not going to say drug A is different than drug B unless the p-value is less than 0.01, which would mean that if the null hypothesis was correct and the drug had no effect compared to, let's say, placebo, the likelihood you would see the difference that you got is less than 1%. So it makes a big, it's what they would call a highly significant result. But 0.05, I'd say, is when you read the literature, they'll always say alpha level of 0.05, p less than 0.05. That's kind of the gold standard you see typically in the literature. Same with power. It's either 80% or 90% power. You'll see that pretty often in studies.
Okay, thank you, doctor.
Sure, no problem. So what do statisticians actually do in the course of the study? So typically they will write kind of early on the statistical analysis plan, which means that once the study is finished and the data is collected, how will you analyze it? What kind of statistical techniques will you use? So everything we just talked about with the alpha level and the null and the alternative hypothesis, all that would go into the analysis plan. So the statistician would write this for you. Sample size power calculations also typically are written up by the statistician into the protocol. So, early on, what sample size is needed? Are we doing a power calculation, meaning that are we actually telling the reader or the reviewer, we're adequately powered to detect what we're trying to find in our study? And again, the analyses, what kind of analyses will we do? Or sorry, this actually means once the data is fully collected, the statistician will analyze it for you. And then they also assist with the abstract, the manuscript writing. Typically, the statisticians are always a co-author on the paper. With the CTSC grant, we always link the CTSC grant number to the statistician participating in your study. And so they become a co-author, and they should, because they're typically writing up the method section of the paper. They help draft the results section, the tables, the figures. They do a lot to get the manuscript to submitted for publication. So these are all the typical things that a statistician would work on. You always want to be mindful of deadlines. So for example, here at the CTSC, the core that we run for biostatistics is obviously limited. There's limited funding to support all the staff that participate. So, we only can work on so much. So, what are the deadlines? IRB submission deadlines can certainly slow things down. Do you have an abstract deadline that you're trying to submit for? So many times somebody will come to us and say, oh, my abstract is due in 3 days. Here's my data. Can you analyze this for me so I can write up my abstract? I have to submit by 11:59 p.m. tomorrow. So, you have to have some, notice, basically 2 or 3 weeks for us to be able to help with these. You just want to keep in mind deadlines. Manuscript resubmission deadlines. A lot of times people will submit a paper for publication. It might get rejected or it might get sent back with revisions. And then there's a deadline to resubmit it. So they might bring in a statistician late in the game to help address some of those comments. But we need time. We can't just do it, overnight. So you want to give ample lead time when you're meeting with a statistician, if possible. And then you keep communicating pretty much throughout the whole process. So the initial meeting is just, the beginning of that relationship. There's always going to be back and forth, especially if you're involving the statistician early on. Many times you don't. Many times you've already done your study, you've collected your study, you collected the data, and then you might just come to a statistician and say, I need help analyzing the data. And we have a form, a consultation form that you can submit to the CTSC. You'll see it at the end here on the last slide. And you can list out what you need. Are you writing up a study? Do you already have the data and you need help analyzing it? So there's a whole bunch of services that we would provide, and you would check off kind of what you would need. So, but the idea is hopefully you could meet early on in the design of your study, so it's cleaner that way because things are set up ahead of time. And again, some statisticians might have stronger backgrounds in your clinical areas. So some statisticians will specialize, for example, in imaging. They might specialize in neurology. So they might be skilled in statistical techniques that are unique to certain disciplines. So for example, here at Weill Cornell, we have kind of faculty level statisticians that might be kind of specialized in certain clinical areas, but not always. Many of them are just going to be looking at all different types of disease relationships. So again, depending on who you're meeting with, you can kind of get a sense of how well versed they might be on your clinical area. Kind of talking about what we just did with when I mentioned the null hypothesis. When you think of the common statistical tests that you'll see in the literature, obviously we can't really go over them in depth today, but typically they're all kind of based on the concept of, what's your exposure, which is your kind of your risk factor variable, your treatment, if it's a clinical trial, what's your outcome, what are you hoping to change, and the type of test you use, statistical test, is based on how these variables are categorized. So I'll just go over a couple of common ones here. So if your outcome is continuous, meaning blood pressure, weight, cholesterol, and you want to keep it on a continuum. In other words, you could define your outcome, let's say it's cholesterol. You could define it as less than 200, more than 200. Now, I want to give a drug to lower cholesterol, but maybe all I care about is, can I get it below 200 or more than 200? Or if it's A1C, can I get it below 6.5 or not? So I can think of my outcome that way, where it's kind of a binary outcome, nice and simple. Or maybe I just want to keep A1C continuous, meaning I want to measure the mean A1C at the end of the study, whatever it might be, just keep it on a continuum. That really is up to the investigator in terms of how you want to categorize it. Ordinal outcomes might be things like you give a survey, and how the questions might be like strongly agree, neutral, disagree, strongly disagree. That might be your typical ordinal outcome, how patients respond to a question. It's on kind of a Likert scale. Categorical outcomes, like I said, binary outcomes, but they could be categorical. They could be, let's say you're looking at pain. Your outcome might be low pain, mild pain, moderate pain, severe pain. You could have like 4 categories. And then multivariable analysis gets into if I want to look at multiple variables and how they impact an outcome. So I want to look at the relationship between diet and diabetes, for example, but I also want to look at other variables in the same scenario. That's called multivariable analysis. So here are just some examples. So, if you're a continuous outcome, if you're measuring a continuous outcome, so what's a good example? Cholesterol level, BMI, a knee rating scale that might go from like 1 to 100. So it can have many values. The Hamilton depression score, which goes up to I think it's like 0 to 35 kind of thing. So typically these are variables where you would present at the end of your study the mean. What's the mean BMI for the patients? What was the mean pain score on the knee rating scale? What's the mean depression score? Things like that. If that's the case, and you want to compare a mean between the two groups, like the mean blood pressure in group A versus the mean blood pressure in group B, that you would use what they call a 2-sample t-test. So these are the common, I'm just going to list here, the common tests you'll see in the literature, the most commonly used. 2-sample t-test is used to compare 2 means between groups. It could be drug A versus drug B, men versus women, just to 2 distinct groups. The other one that's pretty common is the pair t-test. That's when you have maybe one group, but you have repeat measurements on the same patient. So maybe you've got 100 people, and you're going to measure their blood pressure before the intervention, and then you're going to measure it again after the intervention. So it's the same patient over time you're comparing a pre and a post value. That's called the parity test, because every patient is his or her own control in a sense. That's pretty common. The ANOVA test is basically kind of like a 2-sample t-test, but when you have more than 2 groups. So if I have like a 3-group study or a 4-group study, maybe I'm comparing 4 different treatments, I would do an ANOVA test. So we're not going to get into today how these are conducted, but just to be aware that these 3 tests are used when your outcome is continuous and you want to compare means. What's the mean? At the end of my study, I'm comparing 4 different treatments. I'm hoping that I can lower blood pressure. So if I have 4 groups, maybe in group 1, I'll have a mean blood pressure for group 1, a mean blood pressure for group 2, and so forth. And I want to compare across those groups. That would be an ANOVA test. So these all compare means of a continuous variable. They also have this concept called non-parametric tests, where you'll see these a lot in the literature as well, where on the previous slide, these tests are really only supposed to be used if your data follows kind of a bell-shaped curve that you might see before in the literature. So a bell-shaped curve just means your outcome variable is what they call normally distributed, meaning that it follows that bell-shaped distribution. A lot of these tests will have that assumption that your data follows a bell-shaped curve, and if it doesn't, they might break down or might not be adequate or accurate to use. So the kind of the equivalence, if your data is skewed, so for example, if I think of length of stay in a hospital, that tends to be skewed. In other words, you'll see, there's a small number of patients with very long length of stays. So if I wanted to report the mean length of stay, it's not really accurate because the mean it'll be pulled up by the few outliers that have very long length of stays. Or you'll see it a lot with like income. They don't typically report mean income, they report median income. Because if I have 10 people's incomes, if only 1 or 2 of them have really high incomes, if I try to calculate the mean of those 8 people, the mean will get pulled up by the 1 or 2 people that have the really higher salaries. So the median is a more better use of a way to describe your data. So when that happens, another one is tumor size. You'll always see they report median tumor size. They don't report mean tumor size because tumor size tends to be skewed, meaning that it's not really a bell-shaped curve. So these are the types of tests. When you're reading the literature, you just be aware. Wilcoxon rank sum tests. They're kind of weird names. This is equivalent to the 2-sample t-test. You want to compare in 2 groups, but your data is not really what they call normally distributed. The Wilcoxon sign rank test is the same. So this slide basically is the same as the previous slide. So the 2-sample t-test, if you can't use it, you might be using the Wilcoxon rank sum test because your data is continuous, but it's not really bell-shaped, and the mean might not be too accurate to use. So you might report the median. The simplest answer is if you want to compare medians, not means, medians, you might use this test. The parity test equivalent would be the Wilcoxon sign rank test, and the ANOVA equivalent would be the Kruskal-Wallis test. So I'm just listing these here, not because we're going to go over them in depth, just to be aware that these are 3 common tests you'll see in the literature a lot and when you're reading the literature, and they refer to data that's kind of skewed. Like you're doing a study, but it's not safe to report the mean. Let's say I'm comparing length of stay across 3 different hospitals. I can't really report mean length of stay. I might report median length of stay because the mean would be biased by a few people having very high length of stays. So the Kruskal-Wallis test would be used to compare the median length of stay across those 3 hospitals, for example. So it turns out that the previous slide, these tests are pretty robust to those violations, so that even if your data really is not bell-shaped, you typically will get the same answer whether you use these tests or the ones on the next slide. Very rare will you get very different answers, but if you're going to be using a textbook correct definition of what you should be doing, you might want to go with these. And if a reviewer, if you're writing your study up for publication, a lot of times you'll get the reviewer, they'll say, oh, your study is too small, your data is not really normally distributed, it's skewed, you shouldn't be using this test, you should be using these tests. One way to do it is just to do both and to see how your results are they consistent or not. But we don't want to get too much in the weeds on this, but just to these are 3 common ones you'll see a lot in the literature. Okay. The other one that's pretty common is the chi-square test. You'll see that a lot in the literature. That typically looks at variables that are categorical, examples such as mortality status, injury status. You might have a pain score that's deliberately put into categories, 1 to 3 versus 4 to 5 versus more than 5. So I kind of made 3 categories. Presence of disease, yes or no. And a chi-square test typically would be used to compare two or more groups on some, categorical outcome. So for example, like in this picture here, I've got surgery, and I've got one group of patients. I think this is breast conservation surgery. This is something else, mastectomy maybe. And they're comparing these two groups. And what they want to know is there a difference in age between these two groups? So but for whatever reason, they've said less than 46, more than 46 for their age. You kind of have a simple 2x2 table. And you just kind of count up how many people are in the two groups. If I wanted to know, is there a difference between these two types of surgeries with respect to the age of diagnosis, I could run a chi-square test. Now, in this example, the numbers are really tiny. 3 people, 2 people, 2 people, 3 people. When that happens, we do something called a Fisher's exact test, which is for small numbers. Again, not to get you confused on statistics, I'm just really kind of showing the names of the tests that you'll see and when they're used. So something like this over here, much bigger study, you've got, about 57 people in this group, about 62 people in this group, and they're just looking at the age of diagnosis. So a chi-square test would be used on this type of data. Very common, any kind of survey data, like I said before, like when people answer a question on a Likert scale, like strongly agree, disagree, maybe I want to look at how patients respond to a question, but I want to compare it between men and women, or I want to compare it between those that have the disease versus those that don't. That kind of assessment would be a chi-square test to compare basically 2 or more groups when things are categorized. And here's a good example of that. Generally when we speak of associations between exposure and disease, so one of the earlier lectures, they might have talked a little bit about case control studies and cohort studies. That's kind of where this would come in. So for example, this is your classic 2x2 table where you've got, an exposure of interest, such as smoking, and your outcome is, coronary heart disease. This might be a cohort study. So in other words, you're actually going to start out initially by looking at 3,000 smokers. That's that whole first row, 3,000 smokers. And I want to compare them to 5,000 non-smokers. The reason why I have different numbers here is because this is a cohort study. We're just looking at a defined population, and we're looking at how many smoked versus how many didn't. And this is very simple. I mean, we could be much more detailed about their smoking histories, but let's just say yes versus no. And then we look over time to see how many actually develop heart disease. So over time, 84 of the 3,000 smokers developed heart disease versus 87 of the 5,000 non-smokers developed heart disease, because they're in that first column. And that's essentially what they call incidence. So in the smoking group, 84 out of 3,000 is about 2.8%. So that would be the incidence of heart disease among the smokers. They might express that as 28 per 1,000 patients per year. They could express it different ways, but it's typically about 2.8% incidence of heart disease among smokers. Then you look at the non-smoking group, and you've got about 87 out of 5,000, which was just over here, 87 out of 5,000, and that's about 1.74%. So really, what you're doing here is you're saying, is 2.8% different than 1.74%? And the question before about the alpha level and all that we talked about, the null hypothesis here would state that there's no difference between smokers and non-smokers. The null would say smoking has no effect on heart disease. If that were the case, I would expect these incident rates to be identical. The question here becomes, are these different? Number one, is it clinically different, 1.74 versus 2.8? And is that difference what they call statistically significant? So typically they might express that as a relative risk or an odds ratio, which really simply takes the ratio of 2.8 to 1.74. We're going to divide it through. You get a relative risk of 1.6. This just means that if you are a smoker, you are 1.6 times more likely to develop heart disease compared to the non-smokers in that study. That's like what they call a 60% increase in risk for smoking versus non-smoking. And this is what they call in statistics the effect estimate. This is what you observe. That's the increased risk that you're seeing. Whether or not this is statistically significant or not is a different question, meaning that, is this just due to chance? Could this be by chance, or is it real? So when you think of a relative risk of 1 would imply everything's the same. The incidence is the same in both groups. So a relative risk of 1 would be nothing's happening. So the null hypothesis here would be there's no association between smoking and heart disease, which is the same thing as saying your relative risk is 1. Because to get a 1 here, you'd have to have the same rate in both groups. If the relative risk is more than 1, then you have an increased risk of disease. If it's less than 1, you have a decreased risk of disease. But even if you observe that, whether or not this is statistically significant, which means if I wanted to get a p-value attached to it, I have to run some kind of a test, like a chi-square test, to get the p-value, which we're not really going to talk about here. But that's kind of what we're doing in statistics. We're thinking in terms of these tables. Sorry, we have these tables. We calculate the summary statistics, what is the actual rates of disease that we have on the next slide here, and then is this statistically significant or not? The difference between them. When I think of multivariable analysis, that's a little bit different. So, for example, typically you want to see, what is the independent effect of many variables on a single outcome. So, for example, let's say my outcome variable of interest is, how well ACL reconstructions do. So I do an ACL reconstruction on a patient, and I follow them over time, and I want to know how many fail, how many don't fail. So my outcome variable is fail, not fail. And then what do I want to look at? So, okay, let's say type of surgery. That could be my main variable of interest. Maybe I'm comparing 2 surgeries to do ACL reconstructions. So I'll just call it surgery A versus surgery B. And I want to know, does the type of surgery I get predict my success after ACL reconstruction? So my outcome is binary. Either the ACL reconstruction succeeded or it didn't. And I'm comparing, let's say, surgery A versus surgery B. But I want to control for, or I want to take into account graft source. What kind of graft source are they using? Extended rehabilitation, because maybe patients are having different types of rehabilitation post-surgery. The type of cartilage injury they had. So these are all variables that could kind of mess up my results. In other words, let's say I find that surgery B is doing much better than surgery A, but maybe it's got nothing to do with the surgery. Maybe it's because one of the groups had worse injury, more rehabilitation, and so forth. If it's a clinical trial, I don't really have to worry because these variables should be balanced between the 2 groups, but many studies are not clinical trials. They're cohort studies, case control studies. So multivariable analysis just means that I'm looking at multiple factors, and how it impacts a given outcome. Okay. So just one common thing to think of would be if your outcome variables are continuous, any kind of multivariable modeling would be called multivariable linear regression. This is just the term you're going to look for when your outcome is continuous, like cholesterol level, pain scores that have a kind of a big range, like 1 to 100 and so forth. If your outcome is binary, like did your ACL reconstruction fail, yes or no? Did you die, yes or no? Progression of disease, yes or no, following surgery. The type of model typically you're going to see for that is called multivariable logistic regression. This just means you have a binary dependent outcome variable, like survival, yes or no, recurrence, yes or no, and then you're looking at multiple variables in your model. So these are really the 3 common multivariable techniques you're going to see a lot in the articles you might be reading. This one is specific to survival analysis. You've probably seen those articles where they have those Kaplan-Meier curves where they show kind of survival curves over time. This title is used for very specific type of data. It's called time-dependent data, where you're following patients over time to see how long it takes to either survive or time to death, time to mortality. Let's say you're doing, some kind of a surgery and you're looking to see recurrence, time to recurrence. That's called survival analysis. And this is the common multivariable modeling technique for survival type data. But, when you think of the word multivariable, I would just say these are the 3 you're going to look out for in the papers you're reading. This one is linked to continuous outcomes. This one is linked to a binary outcome. And this is linked to a survival outcome. Let's just kind of to know those names. So I think I'll end there. That's kind of a lot, but this is a consultation form link that you can go to. So if you're doing a research study, whatever it might be, it could be a small survey study, any kind of study you might be doing. If you want any type of statistical support through the CTSC, you can just click on this link and submit. It'll kind of ask you some information. It'll come to me, and then we can assign somebody to work with you. It could be simple as helping write up the protocol that you're doing, that you have to get IRB approval for, let's say, or maybe you've already collected some data, you just need some help analyzing it, or you need help writing up your study for publication. Anywhere along the line of the research process that you're in, you can submit this form and come to us, and we can kind of help you with that project, basically. And I think that's it. Okay, I think I'll stop there for now and take any questions. Thanks. I know it's a lot, so it's good maybe just, you have the slides that we sent out, so just have them as a resource. And if you're going to be doing any kind of research study, you can always reach out to me directly or through that link, and that's the best way to do it.
Anyone have any questions? Very informative, very informative.
I know it's a bit technical, but it's hard to do a lot in an hour when it's statistics related. It's actually good to, if you play this lecture again, it'll help you sleep. Just kidding.
I'm not so sure about that.
Think of it as a substitute for Ambien. It works well.
It works well.
Just kidding.
Very informative.
Yeah, it helps because if you're designing a study, especially wherever hospital you might be working out of or location, you're going to have some kind of an IRB, internal review board reviewing it. Somebody's going to review your protocol, and they're going to ask these questions. So it's good just to know the resources that are available to you if you need help. So we're here for that.
That's true. That's true. Well, hopefully what will happen is everyone who's on the call, who's in the class today, they will be submitting. They will start to do research with us. And I'm looking forward.
Yeah. And I think since you're part of this CTSE course, you can just reach out to us and there will be no charge. So whatever we help you with, you don't have to worry about any kind of reimbursement because the CTSE allocates a certain amount of effort to us, biostatistics, to help. So I would just kind of, you would be brought in under that CTSE mechanism and we can assist you with some of the projects. Yeah.
That's great.
Well, thank you.
Right.
Thank you again.
Sure. Thank you very
Thank
much.
you so much.
Okay. Thank you.
Interesting.
Thanks for your attention. All right. Take care. Thank you.
Thank you. Bye.
Thanks, Jesse. Take care. Bye.
Bye-bye.
Hi, you.
Now, if this was money, everybody would have questions about the change or about the profit. But it's very important because the profit comes in terms of our health and understanding our health and doing research and understanding the variables. And if you start to think about the communities of color, you think about the health issues, minority health factors. One of the things, and I'm just going to throw this out, is I want you to think about the fact that in the African-American community, African-American women get breast cancer less than Caucasian women, but African-American women die of the cancer more than other groups. And the question then becomes why? So I'm just throwing it out so that's something that research could really help identify the causative factors. But I thank you. No questions. Well, I thank you. How are the questions coming along, the questions that you answer after the class? How are you finding them?
I still have to catch up.
All right.
Yeah, I think it's fantastic. I haven't said anything, and I'm definitely not on the level that, most of you are on regarding this, but I think it is absolutely dynamic and so informative. And on my level, it's helping me to formulate relevant questions or relevant, to make a relevant presentation based on, a lot of what I'm hearing and reading and what's being presented, getting to the bottom line, but not having a lot of fluff and a lot of extra wording, but yet, I may not be explaining it where you really understand it right now, but I can tell you this is helping me a lot. And I just find it fascinating. that that this is available, and more people should really take advantage of it, especially when we're talking about clinical trials and medical research, and for the community, and having that space and connectivity with the medical professionals to be able to feel that you can, or know that you can ask questions. You can have something that makes a lot of sense to you based on your experience, but yet you may not really are updated with new information, or how you can go about getting the answers that you want, because you're still stuck in maybe 30 or 40 or 50 or 60 or 100 years ago, that mentality on certain diseases or methods of treating people, especially when we're talking about the culture of a particular ethnicity. Some people, have been treated a certain way. We may have seen this, but yet, things have changed somewhere along the line. And in order for us to get to advance ourselves, that I think that people need to, especially people of color, African Americans and others, but definitely to be able to see and be able to what's available, the knowledge, the information, the trials, the going into situations that could help answer, and you could see the turnaround. We can't stay in, stagnant. We cannot remain stagnant. We must move forward. And so again, this is extremely important. I'm very interested, and even
Good. So that means share the information.
Oh, absolutely.
Share with everyone.
Yeah,
John, you have a question?
Yeah,
A comment?
I have a comment. Pardon me. I have a lot of interest in this area now since I began taking this course, and to the point that I just purchased this book by Harriet Washington. It's called Medical Apartheid: The Dark History of Medical Experimentation, Black American from colonial times to the present. And the experiments were atrocious, particularly with Dr. Sims. I think that they tore down that statue.
Yes, they did.
And these are some of the conversations that I think that we as contemporary need to begin to talk about in the process of healing. You have to talk about what went on in the past
to know where to go in the future. Yes.
Yeah, to try to begin healing.
Yes.
So true.
So
I appreciate that. It's so true. Absolutely.
Yeah, thank you.
Experiments.
You're welcome. Now, something, I want you to know that one of the women that was involved in taking down that Sim statue, was a student in the CRA. Oh. And she did a project, and we usually do a project, but I just have to talk to the woman that was in charge of doing the project, has gone on to something else. So I've got to talk to her and see if I could get you guys to do the project, and see if she'll review it for me and send it back, because that was her area. Because, and it's very, community's voice is very powerful. And that's how come the statue was taken down. If the community had not have gotten involved, or didn't even, what happened is the community members wanted to understand Sims's research and what he did. And that started the ball rolling. And that triggered the removal of his statue. And the accolades that went forth for his work, which, when you think about his work, you're saddened by the fact and how he mistreated so many people for that work. And, one of the things that we have to, even now, there are talks going on. I'm going to see if I can find any. Maybe I'll be able to share them. There are talks going on how race and systemic racism has impacted the medical field at large. And there are conversations that are going on. As a matter of fact, there was one last week, and I think it was the National Institute of Health. I will look again because I was supposed to go, but I couldn't make it. And it's important because if we understand the past, then we can get prepared for the future. And in preparing for the future, we can deal with the problems that we've never discussed, because there's a lot of things that we haven't talked about.
That's right.
And
Exactly.
we need to talk about.
Absolutely. Yes.
And some
And-
apologies are needed to, at the very least, need to be said for the
Exactly.
atrocities that were committed against the African American community.
Yes, so true.
Exactly.
Thank you
Exactly.
so much, Mr. Roots.
Ruiz,
Ruiz, okay, yes.
because we have to change the trajectory of this country for my grandkids.
Exactly. Exactly.
Who are living.
And we can't wait for someone else to do it.
Exactly.
That's right.
They're not
That's
gonna
right.
do it. They're not gonna do it.
Exactly.
They're not gonna do
Exactly.
it. So
That's why we're here at this table and this format today.
thank you. And
You're
then the other thing I like to add, if I may, how is technology perpetuating the same system?
Well, now you know something. What you've just done is you've given me homework, because I don't want to say what I think, because I could be off key, off base. But one of the things, if you think about technology, or even if you think about AI,
Mhm.
right now, when you realize that the source for the information that comes through AI gathers from all the documents, historical documents, and everything that's being done. So in some of that, I would think that you may have bias information that has been threaded in. How, I'm not sure, but I think it's something that really needs to be examined.
Well, perhaps
Be-
if I may interrupt, pardon me for interrupting. You have to look at the algorithms, the coders that input the information, their biases that go into the data. So that's
Right, so, yeah, I agree with that. A lot of the information is not fully given. So what people do get a sense of, for change, or get some of the information, a lot is left unsaid. So it becomes a vicious cycle. And the wisdom that should be known about the past or about what can be done now is not given fully. And so we still, technology is an important end. And how does it get in there? Who's giving it out, disseminating all this information? And is it true? Who's checking up on that to find out if in fact the information is, available, or that's being put out there is accurate,
So, you know what that means? That means we need to be involved.
Exactly, I agree.
We need to be involved, and we can't just pass it across. So let us be cognizant of how we can make the next step.
Absolutely.
And one of the things you can do is become a member of our community advisory board. And so, but I'm going to give it more thought, and something, come up with ideas of how you as a community member, you as representing a given organization, can use your organization, your community as leverage to change something through research. So that's what I want you to think about until we meet next week.
Well, I
Okay.
think that's a challenge, but I definitely will do it. I will
Good.
meditate
Good.
on it, pray about it, and see what comes up. Thank you.
Good. You're welcome. Oh,
All
you know
the-
something? I'm going to let everyone go. You know, that is something, they're changing the time.
Right.
Okay.
The
So
ring.
I thank you all.
Thank you so very much. and for the opportunity. Thank
Oh,
you.
Thank you. Thank you all for attending. Have a great week.
You do. Be safe. Enjoy. Bye-bye.
Thank you.